Our next speaker is going to be Dr. Shreyas Ramamurthy. He's a consultant cataract, cornea, and refractive, and extremely distinguished and a charming ophthalmologist, a good administrator, and a friend of all by his very approachable demeanor, a superb surgeon, and has actually taken our Eye Foundation group of hospital to greater heights. He is going to dwell on topo-guided PRK in keratoconus, and he would give us a great input, and that's why I decided to have him for this talk. On to you, Shreyas.
I thank everyone at ARC AIOS for having me here. I hope my slides are visible.
Yes.
So I'll move on to discussing about topo-guided PRK in KC. Dr. Rishi Swarup already addressed it briefly, where essentially cross-linking does a great job of stiffening and gives a stability of the keratoconus, but there is a significant curvature irregularity which is left behind, which can normally be addressed only with the contact lens. So here we have a group of procedures under CXL Plus, like either using a topo-guided PRK or PTK or intracorneal ring segments, which help in giving a certain functional improvement in the vision as well. So how does topo-guided PRK work? If you see here, this is basically the peak of the cone on the anterior float. And what we are trying to do is a combination of a myopic PRK, that is ablation over the peak, and then a hyperopic ablation in the mid-periphery, so that this flatter area we are trying to steepen and overall regularize the anterior cornea. So I'll just go over some general guidelines before taking you all through how we go about planning some of these cases. It works best only in mild to moderate keratoconus patients, and we generally try to have a minimum preoperative thickness of 450. Having said that, you can always ablate a little less, and the main thumb rule is once the epithelium does grow back, you want to leave behind the patient with at least 400 microns, which is generally what is considered as a safe limit for safe cross-linking. With regards to how much can you ablate, now we must remember that this is not a refractive procedure. The idea is to achieve some amount of anterior surface regularization, and essentially it depends on the preoperative thickness and spherical equivalent that we have. We generally try what was earlier recommended was 50 microns of maximum ablation. But over the years, in patients with very good preoperative thickness, there have been papers already published which have tried between 60 to 80 microns and have also found the corneas to be extremely stable and safe as well. But by and large, in borderline thickness corneas, we do not go beyond 50 microns of ablation. You can, however, bring the optical zone size to 5.5 millimeter to save some amount of tissue. Again, like I said, this is not a regular refractive procedure, which we would never step down to 5.5 in a regular LASIK surgery. But here, in terms of anterior surface regularization, 5.5 still works quite well. Emmetropia is never the goal. We must understand that CXL itself has a flattening effect and unfortunately has a variable flattening effect. Patients who develop more hairs can have a little bit more flattening, and our aim is to ensure we never push the patient into hyperopia. So definitely 20% or 30% undercorrection is definitely recommended. Accelerated CXLs, we do see that the amount of flattening is a little less, so probably you can go a little bit more, whereas if you're doing a conventional cross-linking, the amount of undercorrection has to be even higher. Centered versus decentered, it works best with centered. I'll show with a few examples later. Having said that, it does not mean it does not work with decentered cones, but the amount of improvement that you get in uncorrected and best corrected visual acuity is best in centered cones. If you don't have access to a topo-guided laser, can you do a conventional wavefront treatment? Yes, there have been a couple of publications on this where they have done so. But the challenge here is in these highly aberrated corneas, getting a repeatable wavefront is a bit of a challenge, and we may not be able to achieve it consistently, and therefore it can give rise to variable results. So I'll quickly take you all through step-by-step planning on how we actually go about it. I use the Wavelight platform, and therefore I'll show the basic planning, though the basic idea of how we plan a procedure remains the same irrespective of which platform you're using. So most important is to get these repeatable 6 to 8 scans, as you see here. Now, once you get the repeatable scans, how do you know they're repeatable? One of the ways each machine has its own score, you have something called a mean deviation score here. Anything which is more than 0.1 is generally not acceptable, and you want it to be below 0.1. So the idea here is we remove some of these outliers, and then you see once you remove the outliers, you're able to reduce the mean deviation score to a more acceptable level. And that is the very basic which you have to do before you proceed with the treatment itself. Next comes the Q value. Dr. Rohit Shetty has published a couple of papers on this where he has shown that this Q switching or reducing the amount of Q can be beneficial. It's more beneficial when the Q value is quite high to begin with, especially if it's greater than 1, the machine will not allow you to proceed and you have to bring it lower. But even with patients with 0.8 and 0.9, you might do well to first adjust and reduce the target Q value a little bit. Now, with regards to the refractive power itself, what do we go on to correct? Now, generally what we say is with regards to the sphere, you go with the subjective refraction. Of course, obviously, this machine is more of a Placido-based and will not give you a clear idea of the sphere. But when it comes to the cylinder in these irregular corneas, we tend to more go with the topo-guided cylinder rather than the refractive cylinder. And I'll show you in some cases where you have a great discrepancy between the refraction and the topography guided measured cylinder, how we go ahead and plan the treatment. Now, first and foremost, what we have to do is we have to set it at 0 power, as you can see here. Eliminate whatever power in the target which you're going to treat, make it 0 power, and then look at the ablation profile. You have to correlate the ablation profile with the sagittal curvature of your of the cornea which you're going to treat on your topography. As you can see here, the maximum ablation and the maximum area of elevation on your maximum elevation or as well as your maximum curvature do match. And this shows that your ablation profile is matching with your topography, and then this is when you proceed with the subsequent steps in planning. More than the sphere, we are here looking to debulk the cylinder, and subsequently, once your 0 power itself, as you can see here, in some cases might take away quite a bit of tissue. And if you're trying to limit yourself to about 50 microns, already 36 microns has gone away in this. So you're actually left with only a little bit of tissue for you to ablate. But in some cases where the irregularity is not high, you might be able to ablate more of the power, as you can see here in this patient. And the other thing is, what is the axis that you use? So here there is a patient with a very good correlation of 15 and 15 degrees, both in your refraction as well as your topography. And therefore, these are patients where it's quite easy. You go ahead and directly key in the amount of cylinder that you can do to reach somewhere between 50 to 60 microns of maximum ablation and treat the patient. But let's look at this next example, where you can see here that the not only is the magnitude different, but also the axis, which is 100 degrees and 165 degrees, quite widely different. Yes, generally we go ahead with the topography, but one way of correlating is to look at the anterior float on your topography or on your pentacam. And if you can see here, the axis which you are going to correct should correlate better with your anterior float. And if you can see here, if you draw a line through the central point of the steep axis, it correlates better with the 165 axis, as you can see here. And that is the axis which you go ahead and treat, or at least come closer to the topography guided axis. Go on increasing the cylinder, as I mentioned. Just one second. Yeah, go on increasing the cylinder, as I mentioned, in steps till you reach your target maximum ablation. You can reduce your optical zone size to 5.5, as already said. Another small cheat method which you can use to reduce the amount of ablation is if the patient is accepting a low hyperopia, you can add a small amount of hyperopic cylinder. And as you can see in the same picture, by just adding a little bit of hyperopic ablation here, the maximum ablation has been brought down from 59 to just 50 microns. And you can go ahead and treat this patient. So adding a little bit of hyperopia doesn't necessarily affect your final overall visual outcome, but gives you a little more tissue to play around with so that you can debulk the amount of cylindrical correction that you can do. So as you can see here, some of the patients with the results were preoperatively a patient with 636 and BCVA of 6.9, improving to post-op UCV of 6.6 partial and a BCVA of 6.6. This is a patient with a very well-centered cone, as you can see here on the posterior float, very well-centered. These are ideal patients for topography guided treatment and have excellent outcomes. Having said that, there are patients with decentered cones as well, as you can see here, who do quite well with just topography. This patient underwent almost no refractive correction, just a topography guided regularization. As you can see here, the patient went on to achieve almost a 6.6 visual acuity with just a topography guided regularization. A few more examples where you can see the anterior corneal symmetry has greatly improved from the preoperative period. It has become a much more symmetric bow tie. And these central nipple cones are where it works best. As you can see here in the postoperative period, it's almost as if the keratoconus has completely disappeared. Now, whether you want to use a PTK or a manual method to remove your corneal epithelium, that has always been a point of discussion. We must remember that the topography is being measured, and all the topography guided measurements and whatever we are inputting till now is based with the epithelium on. So if you're removing the epithelium, as we all know, the epithelium can be quite varied in a keratoconic patient, thinner in certain areas and thicker over the base. And if you're removing a varied thickness of tissue, the underlying topography might be quite different. So therefore, using a uniform PTK to remove 40 or 50 microns of epithelium, you'd probably do better to maintain the anterior corneal contour to what it was in the preoperative period when you measured the corneal topography. There are still some unanswered questions. How much ectasia? What is the maximum ectasia that you can correct? What is the attempted correlation between your amount of correction and the final refractive outcome that you get? And as I mentioned earlier, what is the dosage of CXL? Now, if you're using a customized cross-linking, what pattern of maps do you use? And what amount of cross-linking that you use along with your topography-guided treatment to further augment results? These are still early days, but we are getting some exciting early results. And I think a combination of customized cross-linking with topography-guided treatment would be the future. Thank you so much for your kind attention.